Hi, my name is Lindsay Camp. I'm an Auburn University nurse practitioner student, and today I'm going to be discussing the wound prep and wound care associated with the laceration repair, as well as demonstrate 5 interrupted sutures, which is how I'm going to begin this video. Before getting started with demonstrating my sutures, I would like to note that prior to any sort of laceration repair, the nurse practitioner should thoroughly irrigate the wound, cleanse the wound, perform local anesthesia, and set up a sterile field. However, for the purposes of this video, I will not have a sterile field or don sterile gloves, but that is a important aspect of a laceration repair. And I'll talk about the other components of wound prep later in this video. To begin, I'm going to gather all my needed supplies, which include pickup, scissors, and my loaded needle driver. To load a needle in your driver, you want to load it at the tip of your driver on the very back of the needle itself, and then lock your needle driver into place like so. I'm then going to use my forceps as needed to allow me to fully penetrate the dermis. I'm going to insert my needle at a 90-degree angle to the skin and to the wound, using a wrist twisting motion to be able to approximate the edges of the wound together. And ideally, you want to go a few centimeters away from the wound to not put too much pressure on it and therefore cause the skin to invert and make a more prominent scar. So I'm going to pull it through, and I'm going to leave about a 1.5 inch tail on my short end of my suture to allow me to make a surgeon's knot, which is the next step of a laceration repair. To make a surgeon's knot, I'm going to wrap my long end of my suture around my needle driver 2 times. 1, 2. I will then grab the short end of my suture and pull it through. This is a surgeon's knot, the first step of a laceration repair. The next step will be to make several passes to make knots over the surgeon's knot to strengthen the suture. To do this, you will do the same thing to make the surgeon's knot. However, you will only wrap it 1 time around the needle driver, and you will alternate the direction of wrapping it around the needle driver with each pass. For instance, I'll wrap it once, find my tail, pull it through, and again, but different direction, 1 time, find my tail, pull it through, and again, last time. Ideally, you want to make about 4 to 5 passes to ensure that the suture will be strong and support the wound. So there's my first suture. I'm now going to cut at an angle and make them even. Now I'll move on to my second suture and repeat the process. Typically, you want to space out each suture about 10 millimeters. However, the size and depth of the laceration is ultimately going to determine that. So I will load my needle driver, use my forceps as needed. I'm going to try to make it an equal distance compared to my first suture. Full layer of the dermis. Again, my surgeon's knot. 1, 2. Different direction, wrap it once, pull, again, different direction. Last pass. Again, load your driver. Go in at a 90-degree angle, even with your other suture. Again, kind of a wrist twisting motion. surgeon's knot, 1, 2. And last pass. So what are some goals of laceration repair? Well, the main goal is going to be to approximate the edges. However, it's also important to achieve hemostasis, restore functionality, and also to promote optimal cosmetic results. So again, and again, I would like to note that ideally this would be done in a sterile field with drapes and everything. Last pass. All right, we'll cut and then do our final suture. Just leaving a little bit of tail with each one. Make it as even as you can. So let's go ahead and talk about some important things that the nurse practitioner should assess on a patient that presents to the clinic for a laceration. The first one is going to be, when did the laceration occur? And this is because ideally lacerations should be repaired within the initial 12 hours of the laceration. Last pass. And again, the more passes you make just ensures a stronger suture. And these are my 5 sutures. So now let's talk about some important assessments that the nurse practitioner should do prior to initiating a laceration repair. The first one is going to be that the nurse practitioner should assess the laceration itself. We talked about asking about the timing of it, but it's also important to assess the location. And this is because the location is going to determine the size of the suture. Typically, it's recommended for a facial laceration that a 5-0 or 6-0 suture is used. For a laceration on an extremity, it's recommended to use a 4-0 or 5-0. And then for a laceration on the trunk, a 3-0 or 4-0 suture is recommended. It's also important for the nurse practitioner to assess for the potential of any debris or foreign bodies in the laceration as well and remove them appropriately. Lastly, the nurse practitioner should assess the neurovascular status of the area around the laceration to ensure that functionality and sensation are intact. If either one of these seem to be diminished or there was concern of neurovascular status, the nurse practitioner should refer the patient to the emergency room to have general surgery manage the laceration repair. There are a few other instances in which laceration repair should not occur in the outpatient setting. Some of these include a full thickness laceration involving the lip, eyelid, or ear, any deep penetrating laceration of unknown depth, a laceration that has been contaminated and may require debridement, and lastly, a laceration of the palms of the hand or soles of the feet should all be referred to surgery for further management of the laceration repair. There are some other components that the nurse practitioner should assess for. especially regarding the patient's past medical history. It should be important for the nurse practitioner to verify any allergies, specifically to iodine, anesthetic agents such as lidocaine, and adhesives. Also, the nurse practitioner should screen for any chronic medical conditions that could delay wound healing, such as diabetes. It's also important to ask for if the patient has any bloodborne diseases such as HIV. And lastly, the nurse practitioner must be sure to ask the patient when their last Tdap vaccination was. Based on the up-to-date guidelines, it's recommended that individuals undergo 3 tetanus vaccinations in their lifetime. And as long as the most recent one has been within 10 years, the patient is covered from tetanus. However, it's important to note that a Tdap booster can be given every 5 years. So it's important to remember that with laceration repairs. Once all the screening and assessments have been done, the nurse practitioner has confirmed that this laceration can be repaired in the outpatient setting. The nurse practitioner would then irrigate the wound. Irrigation of the laceration can be done with either normal saline or water, which can either be sterile or tap water. It's important to note that irrigation with betadine or povidone iodine should be avoided because these impede the healing process. After irrigation is complete, the nurse can move on to anesthetizing the area to promote patient comfort. There are 2 different types of anesthesia associated with lacerations. The one that I'm mainly going to talk about is going to be local anesthesia. However, I would like to touch on a digital block. Digital blocks are primarily used for lacerations that involve the fingers or the toes, and it's important that the nurse practitioner is aware that if a digital block is being performed, the use of lidocaine with epinephrine should be avoided. There should be no epinephrine with a digital block. However, with local anesthesia, the nurse practitioner can utilize clinical judgment in deciding whether or not to use 1% lidocaine with or without epinephrine. This is primarily going to be determined based on the amount of bleeding noted at the laceration. To perform local anesthesia, the nurse would simply draw up 1% lidocaine and put a subcutaneous needle at the end of the syringe. Inject the needle bevel up fully into the subcutaneous tissue around the laceration, and as the needle is slowly being withdrawn, the nurse practitioner should slowly inject 1% lidocaine. And this can be done as many times as deemed necessary to ensure all areas around the laceration are covered. Once local anesthesia has been performed, the nurse practitioner can then ensure sterility. This can be done by donning sterile gloves, setting up a sterile field, and cleansing the wound with either betadine. However, if there is a betadine allergy, some diluted Hibiclens would also work just to ensure that the wound is clean before beginning the laceration repair. Now, there's some important educational components that should be mentioned to a patient after a laceration repair has occurred. Specifically, for the initial 24 hours after repair, the area should be kept covered and dry. After the initial 24 hours, the patient can uncover the wound. However, it is important to still keep it as dry as possible. It should also be instructed to the patient to apply a antibiotic cream such as Neosporin or bacitracin to the area twice daily. If this is unavailable to the patient, Vaseline can also be recommended. Some key patient teaching points post-laceration repair would be to avoid submerging the repaired laceration in water. So they should avoid sitting in a bathtub, hot tubs, and recreational swimming until the sutures have been removed. And that brings up another good topic. When should patients be instructed to return for suture removal? Well, it depends on where the sutures were placed. Sutures on the face are typically removed in 3 to 5 days, whereas sutures involving the scalp or the arms are recommended to be removed in 7 to 10 days. And sutures on the legs, trunk, hands, or feet are typically recommended to be removed in 10 to 14 days. And it's very important that the nurse practitioner educate patients on these follow-up instructions, because the longer sutures remain inside the wound, the more prone the wound is not only to infection, but also to prominent scarring. Thank you for watching my video.